Well, good evening and welcome to tonight's lecture in the Global Public Health Lecture Series. I'm Peter Kern, the Director of the Global Public Health Program, and I'd like to welcome all of you on behalf of our program and the Institute for Health and Humanities, which has co-sponsored this lecture series. Tonight, we have a really fascinating lecture from someone who is part of the University of Montana, and that is Dr. Martin Blair, Executive Director of the Rural Institute for Inclusive Communities. And Martin's going to talk about building inclusive education opportunities for Kenyan children who are deaf and or blind. Martin Blair began his career as a special education teacher. Following that experience, he spent the next 2 decades at Utah's University Center for Excellence in Development Disabilities, the Center for Persons with Disabilities, as director of the Utah Assistive Technology Program, chair of Utah's Interagency Outreach Training Initiative, and policy director for the National Center on Disability and Access to Education. So as you can see, he's really well connected in this field. In these various roles, he has built trusting collaborative relationships with colleagues from a variety of disciplines in university, community, state, and national circles. In 2013, Dr. Blair assumed leadership of the University of Montana's Rural Institute. Dr. Blair has presented over 50 papers to national and international audiences and authored dozens of articles. He currently serves as the co-chair of Public Policy Committee of the Association of University Centers on Disability. Dr. Blair's work is focused on improving the quality of services and support for individuals with disabilities and their families by working closely with trainees. Center staff, university faculty and administration, state and federal legislators and administration officials, and those who are the primary beneficiaries of the services and support that he and his colleagues provide are appreciative of the work that Dr. Blair has done. So we're really fortunate to have him here at the university and to have him as part of our lecture series. So please join me in welcoming Martin Blair to the lecture.
Karibu, karibu sana. Anybody here speak Kiswahili? Well, now you do. Karibu, or karibu sana is welcome, and glad that you're here. I'm Marty Blair, and I've been here for, it's going on 5 years. But I've been connected with the University of Montana for about 10 years, and with the state of Montana through the Office of Public Instruction and Special Education. So coming here was not new to me, but coming to UM was certainly a new experience and has been. I know that we've got someone from MSU Nursing. Good for you. Anybody else from the nursing program? All right, a few of you. Good. Wonderful. Welcome. The rest of you are UM students. How many of you are involved in health sciences, health medicine related stuff? More business, economics? I did economics because I know of him. Pre-med, I know we've got. Good, so we've got a few folks here. Well, I'm going to tell you a little bit about my trip to Kenya and how this all happened. Had you asked me a year ago if I would be doing any work in Africa or East Africa, I would have laughed at you. Africa's a place that I've always wanted to work, but this whole experience came about less than a year ago. I had done some work in South Korea some years ago, but other than that, had not done international work. Many years ago, I lived in Argentina and did some humanitarian and service work there, but I never dreamed I would get to East Africa. This picture here, I don't know how well you can see these pictures. Can you see that? That's a male giraffe, and I took that with my phone. I'm so excited. Some of the wildlife pictures in here I took with my phone very early on a Saturday morning. Has anybody ever been to Kenya here? A few of you have. Have you ever seen a giraffe up close? The males are absolutely immense. I'm going to talk more about global health here in a minute, but I thought the giraffe was completely awesome. So, how did this happen? About 10 months ago, our national office in Washington, D.C., the Association of University Centers on Disabilities, got some funding to engage in what they call a citizen exchange program. The Mansfield Center here on campus has one of these large grants, a citizen exchange program, but it's mostly with Asian countries. And so I had done some work with them, hosting fellows from Laos and from Vietnam. But our National Association set this whole thing up that it was going to be disability specific, that they went out to people in NGOs, non-government associations, and what they call civil society groups. These are advocacy organizations that deal with disability, that had an interest in inclusive education. And there were actually 10 of them. 5 came from Kenya and some came from other countries. They needed a place to come. So our National Association called me and said, would you take somebody on for 3 weeks? And then they dangled the carrot out there and they said, of the hosts, 3 or 4 of you will get to travel to the host country. Well, that was enough of a carrot for me because of my interest in Africa. So in May of last year, Elizabeth Shia Community, and there's a picture of her I'll show you in a minute, she came to the United States for 6 weeks. 3 of those weeks she was here in Montana, in western Montana. And she and I traveled all over visiting with early intervention and early childhood training programs. We met with pediatricians, we met with policymakers, we met with families, just so that she could get an idea of how our system works. At the end of that time, at the end of that 3 weeks, she and I developed an action plan. She had already had an idea that she wanted to develop this framework, an early intervention framework in the country of Kenya, which I'll explain here in a bit. So she had the bud of an idea. While she was here, that expanded and grew. And at the end of that 3 weeks, we developed an action plan that would enable me to go to Kenya and help her continue this process. So in October, I got to go to Kenya. You can't see it real well. Elizabeth is the woman in the middle. This is a group, the NGO that I was with. This is their staff in Nairobi, Kenya. The organization is called Sense International. Sense International is actually out of the United Kingdom. It's a UK organization, but they have offices, and I'll show you in a second, they have offices in different parts of the country, very much focused in East Africa. Their role, specific role, is to identify children with deaf blindness or multisensory impairment. So if I say deaf blindness or MSI, that's what I'm referring to. And to provide, you want the lights down a little? I even know how to do that. She told me how to do that.
I think we can see the slides better.
How'd I do? All right. All right. I am.
Put the giraffe up again.
Put the giraffe. I'll come back to the giraffe just for you. There's even a better picture of some wildlife here. Where was I? Anyway, so this organization, they do a lot of policy work in Kenya to work with people at the federal level and at what they call the county or the state level to engage in programs. They also are program providers themselves. They provide services to families doing what they call community-based rehabilitation in the homes of families that have children who are deaf and blind. They work with schools who have deaf and blind students enrolled in those schools, and they are providing technical assistance and training to the teachers. But it's a very small organization for a large country. Sense International, as I told you, is in different parts of the world, very much focused here in East Africa, but they do have offices in Bangladesh and other places, Romania and Peru. When I found this out, I had already committed to the folks in Kenya. It took me about 30 hours each way when you've got all the layovers. And I really wish that I'd gone to Peru, because that's a lot shorter trip. But they don't have giraffes. So it's been exciting to work with this group. And they get, again, most of their funding out of the UK, but they're striving to go from a small NGO to something much bigger. And I'll explain that a little bit. Let me tell you a little bit about Kenya by the numbers. I pulled these several months ago. There are about 49, just under 49 million people in the country of Kenya. Most of them are in the south, along the southern border. There are some up in the north, but most of them are along the south. They estimate, and that's just a very rough estimate, about 877 births per day. They estimate about 203 deaths per day. The reason those are estimates is because there is not a mandatory birth registration or death registration like we have in our country. So kids can be born, people can die, and there's no official record oftentimes. Net migrations, negative 27. So in essence, what you can see, the important number here is the net change per day, is that Kenya is a growing country. They have a positive migration, people coming in. It has been, up until this year, considered a bastion of democracy and freedom, but it's not so much the case in the last few months. That is changing. But anyway, that's a little bit about Kenya. There's some interesting work going on with this idea of inclusive education. When I say inclusive education, what I'm talking about is children with disabilities being included in what we would call a mainstream or the regular education system, that they are being included. This came out in 2016. This was a report that was commissioned by the Parliament in UK that was an initial, not initial, but it was a response to some conversations that have been going on in the country since 2010 about what it means to include children with disabilities. How do we do it? What do those programs look like? What are the policies and programs and training that needs to be in place? So this is a report that we used as the basis for our work, and I just give that to you as a good reference. In fact, some of the work that Sense International is doing is highlighted here as well. I think what's really important about this is the quote. Let me go back to that. This comes from a parent of a child with who has multiple disabilities. When you have a child with a disability, poverty knocks on your door. I think those of us that work in the disability community have long understood that disability is just not an issue of being able to function, but it's a poverty issue. And when I've been engaged in conversations with international partners, many, like the development banks for Asia and Africa and different parts of the world, they don't necessarily talk about disability. Even the World Bank. There's some discussion of World Bank or of disability, but the real focus is on poverty. These are poverty issues because when you have a disability, you are not able generally to provide for yourselves because they just don't have the services or the protections for individuals with disabilities. So let me talk specifically about deaf-blindness and MSI, multisensory impairment. This comes from Sense International. I think this is fairly it's commonsensical, right? You think about someone who has a disability, they, particularly if they can't hear or they can't see, or have a combination of can't hearing and of not being able to see and not hearing, communication with family, communication with others is impaired or just virtually non-existent. That's not always the case. Helen Keller is a great example of someone who had dealt with that. And we have programs in this country and in other countries where we teach people who are deaf-blind to sign and to communicate. But if you don't have access to those services and don't have policies to protect those rights, that can be a real issue. Isolation. So if you're not able to communicate, certainly isolation is an issue. Isolation has tremendous impact, or impact's not the right word, but implications for development. For social development, for language development, that's a problem. Getting information, we all depend on communication back and forth. Mobility. How many of you have ever tried to cross the street with your eyes closed? You wouldn't do that, really. And if you've ever been to a large city, well, a large city anywhere, but certainly in a place where pedestrians have no rights, if you imagine being a person that can't see or can't hear trying to cross a busy street. What I liked about Nairobi is that we were part of the time in Nairobi and part of the time in Western Africa and Western Kenya. And there are places in the main streets where there are 3 lanes wide from 4 or 5 directions coming into a roundabout. And there are people darting in and out. There are signal lights for some reason in a roundabout, but of course they don't work. And people on motorcycles and buses. So those of you that have been to some of these countries, you know what I'm talking about. But can you imagine being a person who can't see well or can't hear well or can't navigate well mobility-wise, being able to get through that kind of a situation? If you can't get where you need to go, you can't work, you can't get health care, those sorts of things. So anyway, those are the effects of deaf-blindness, but it's fairly common sense. So, does anybody know or think they know, or want to guess at causes of deaf blindness?
Scarlet fever can cause deafness.
Okay, deafness, scarlet fever. Okay, other thoughts? Yes.
Vitamin A, beta-carotene deficiency,
Okay, vitamin deficiencies. Okay, nutrition.
whooping cough.
Whooping cough. Okay. Polio. Yeah, polio. All of these, much of what you're saying, these are preventable things, right? Now, in the United States, people who are deaf-blind, typically it's a congenital or a genetic issue. The preventable causes of deaf blindness we've pretty much taken care of, not completely. But in Kenya, you have the congenital genetic causes, but the primary causes are preventable. So if you saw my next slide, I snuck into that. Maternal rubella is a huge issue. They do not have mandatory rubella vaccine, as we do in this country. Meningitis and cerebral malaria. Obviously, these are things that you can prevent. I was in a school, the Maseno School for the Deaf and the Blind, which is in western Kenya, right on the shores of Lake Victoria, if that gives you a sense of where it's at. And, you know, Westerners, we're real good do-gooders. We want to help, right? So in this school, they had connected with some folks in Europe, and knowing that avoiding bug bites and needing treated bed nets for the 100 or so kids that live in this residential school, that was an important thing. People in Europe got together and sent not 100, not 200, but somewhere in their neighborhood of 800 bed nets. Well, the school used all they could. They gave to the community what they could, and the rest of them were used in the garden to keep the bugs off their garden. I thought that was kind of, I didn't take pictures of that, but the garden had more screened mosquito nets than anything else in that whole school. These are preventable things, and if we look in countries that don't have good hygiene, don't have good access to water, etc., issues like meningitis can be a real problem. When I was there, and I've got this later on a slide, I was there for 2 weeks. And in those 2 weeks, there was a malarial outbreak, and 26 people died on I think that was day 11 or 12 for me. And that was in one little community. There were families that were losing 2 and 3 people in a family. And this is a completely preventable disease. One thing I thought was interesting also was in the billboards. Billboards had 3 things on them. You know, we have billboards for all kinds of stuff, but in Kenya, in Nairobi, I saw billboards for 3 things. Beer, I don't know why, beer, but something Tusker Husker or something like that. Something like that. Do you know what that is? Tusker. So Tusker beer. Like insect repellent, because malaria is a huge issue, and condoms. Those were the 3 things that were on their billboards, because condoms, HIV/AIDS is a huge problem. So those were the 3 things that and I don't know how alcohol fit into that, but that was my research. My research is what's on the billboards. So let me talk a little bit about some of the social service challenges they have. This was a meeting that I had. The man in the middle that's smiling, I'm just kidding. He's a lot nicer, this guy right here, Dr. Kabaka. He's the Deputy Minister of Health for the country of Kenya. And the other folks, that's Elizabeth to his right, the other folks there are professors from the Kenyan Medical Training College in Nairobi. And we had a wonderful discussion about health issues, about some of the concerns that they have. In fact, when I asked, well, I'll come back to that in a minute. We had a conversation about the policies and things that are going well in Kenya. And Dr. Kabaka, he took the floor, which is, you know, what you would expect from the deputy minister. The others kept their mouths shut. And he was explaining the wonderful policies they have to take care of people with disabilities, to provide services for people with disabilities, to provide training so that families can be served, and he went on and on and on. And towards the end of that, I asked him, so how well are those policies working? And he stammered a bit, and he said, well, it's okay. And I said, no, really, how are these policies that you've developed over the last 10 or 15 years, how are they really being implemented in your country? And he took a deep breath and looked down and he said, well, that really is the problem. We have the policies, but we have no way to implement those policies, even in Nairobi, let alone in the more rural parts of the country. As soon as he said that, the rest of them, they all took a deep breath, and the conversation became very lively about ways that we could help them to implement the policies that they already have, ways that they could learn lessons from us in our U.S. system from the mistakes we've made about policy implementation. We started talking about individuals that they could work with. We looked at connections with universities in our country and universities in their country. But there had to be an admission that the best policies in the world don't really help people. What it really comes down to is how well are you implementing the programs that the policies are based on. And I think that's an issue that we have in this country. They're very new at this whole idea of inclusion and disability policy, but they recognize it. So when we had the more lively conversation, I asked, what are the big issues? You've got the policies, but what are the issues? And these are the big four. Transportation. They do have a public transportation system, but it's not accessible to people who have any type of impairment. If anybody's ever been to Kenya, have you ever ridden in a matatu? A matatu is like a little minivan, not a big minivan, like a little minivan. And they passed a law 2 years ago that you could only put 14 people in it instead of 18. And I never had the opportunity to ride in a matatu. Someday I might. But transportation to and from school, for example, for children, for any child, it's the responsibility of the family. It's the responsibility, their responsibility to get the child to and from. There's no school transportation unless you go to an expensive private school where you pay for that service. But most families don't have that option. So transportation is an issue. One of the things I thought was interesting, in one of the slum areas that we visited, there is a budding business among mothers that have children with mobility impairments. They pay each other a week at a time to carry each other's children to school on their backs. It's a way for a family, a mother, to earn money for her family, and it's a way for others to get their children to school. And they take turns, so they're all paying each other. Oftentimes they have more kids than just the one with a disability at home, but they will carry the kids, they will do whatever they have to do, and sometimes it's 2 or 3 or 4 kilometers. And that's in the cities. In the rural areas, the transportation just is non-existent. Funding is an issue. They do have what they call a cash transfer program, wherein the federal government will pay funds to a family to help them, about $200 a month. That's what, 20,000 Kenyan shillings. But $200 a month doesn't go very far, even in Kenya. Most rent is more than that. So funding is a problem. Funding for teachers. In fact, one of the teachers that we met, Ms. Beatrice, she makes, if she works there for at least 10 years, she will get up to $120 a month as a teacher for preschool and kindergarten. Professional expertise and training, that was the focus of this discussion with these medical folks. They are hungry for learning how to deal with disability, how to diagnose, how to screen, how to diagnose, and how to treat issues of disability. And again, policies without programs, that was really important to Mr. Kabaka. Everything in Kenya is new. Kenya is functioning on a constitution that was finalized in 2010, a little less than 8 years ago. In that constitution of 2010, and by the way, they separated from Britain in 1964, and it took them nearly 50 years, almost 50 years to go through a dictatorship and to go through all kinds of different things. But in 2010, they developed a new constitution which protects the rights of people with disabilities. Again, that's the policy part, but they don't have the programs to back it up. In 2010, and then launched in 2013, was this idea of devolution. which is an idea of federalism. There's a strong federal government, but they send the money, and we say that's block grants in this country. They send large chunks of money to the counties, which there are states, to develop the programs and services for people, human services, et cetera. But that's only been happening for the last 4.5 years. This is a very, very new system for them. They've never dealt with this type of a government situation before. So all of a sudden you have 47 counties in the country of Kenya that are getting this huge infusion of millions, hundreds of millions of dollars, or Kenyan shillings, to develop programs. They don't have the expertise, they don't have they have the policies in place, but they have no idea how to implement them. They don't have the personnel to implement the programs or to understand really what to do with the money. And this is all happening within the last several years. One of the things that they did develop was this Kenyan Institute, or Kenya Institute of Special Education. That is a model that is still very central. When someone goes to a university and learns or gets their degree to become a special needs educator, they get connected to a registry. They don't go to the schools in the different counties around the country and apply for jobs. They go to the registry, and a county government will say, we need this many teachers with this kind of expertise, and they are deployed from a central office. So there's still some centralization, a strong central government, and that has implications. That has strong implications for how you develop capacity and expertise in local communities. If you're continually getting people deployed from other parts of the country, local communities have a difficult time developing expertise within their own community. But the nice thing about KISE, is what it's called, is that ongoing training and certification happens centrally, so there's some level of consistency. So as you talk about getting children with disabilities engaged in schools and engaged in inclusive education, they do have a centralized system for consistency, but they don't have capacity in local communities, and that's something that we are working on. Societal challenges. I mentioned some of this before. Birth registration, 3 of every 4 kids, it's estimated, in urban areas, and just over half in rural areas are registered. There's no need for a birth certificate unless you need some sort of government funding or government support. And it's such a hassle that most people, not most people, many people just don't go through the hassle. Secondary school participation, it's under 50% for both genders. So as far as education goes, children will go to school typically until age 12 or 13, and then they're done. There are no early childhood development statistics. Public health priorities, again, I told you that Dr. Kabaka said very clearly, what are your priorities? HIV, AIDS, and malaria in that order. There was no question about that. I told you about the people with malaria. It is estimated that 46% of the people, that's over 24, 25 million people in that country live in poverty. 19% in extreme poverty. Just by way of comparison, the U.S. numbers, and of course the definitions are a little bit different, but the comparison is 10 to 14% in our country on average. So it's a country that's not well educated, the people are not well educated, and there's a lot of poverty. All right. Anybody heard of the Sustainable Development Goals, or SDGs? This concept is driving development in many third world countries, certainly in Kenya. Every meeting we were in, there was some discussion about the SDGs. There are 17 of them. They were just adopted in 2015. The idea is that these goals will be accomplished by 2030. This is the second edition of these goals. There were some that were a decade or 2 ago. But there are 2 that are of particular interest. One is about ensuring healthy lives, and the other inclusive and quality education. So any of the work that any of us do, I learned quickly, has to be related to the SDGs. It is the funding agencies like United States USAID, Agency for International Development, and Great Britain has a similar program. They are calling on NGOs and people that are doing work in these countries to focus all their work on the SDGs. So this is what is driving our work, our framework there. There are some good things happening. I told you about policies. They have a Kenyan Persons with Disabilities Act, similar to our Americans with Disabilities Act. It was passed in 2003. It's a great policy, but there are really no teeth to it. They have the policy, but there are no programs really available. Free and compulsory primary education. 4 out of 5 kids in the urban areas, 3 out of 4 kids in rural areas go to school. We are fairly certain that kids with any type of disability, particularly those who are deaf-blind, and we estimate there's about 17,000 Kenyans who are deaf and blind of all ages, many of them, if not most of them, are not attending any type of education. In fact, I was in the Kilimani School for the Deaf and Blind. Well, it was Kilimani School, and they have a section, a classroom for kids who are deaf and blind. Just 2 months before I got there, in August of this year, they had a family bring a 26-year-old man who had never been in any type of schooling. The parents finally they're getting so old they didn't know what to do with him, so I thought they might as well just enroll him in school. They enrolled him in the 1st grade, and they took him. Certainly not age appropriate, but it's a way for the family to care for this man. And that is very common, that kids do not get engaged in school early on. I don't have data to support this, but my colleague Elizabeth indicated that most of the children who are deaf and blind that come to school come between the ages of 8 and 10. Families have tried to deal with it, or they've been embarrassed, or for whatever reason, they haven't had their child go to any type of a schooling situation, or they couldn't afford it. But by the time the child is 8 to 10 years old, they realize that something has to be done. If you know anything about human development, by the time you're 8 years old, the critical communication skills, the critical development, that window hasn't completely closed, but the key development years are 0 to 5, typically. They have a council for people with disabilities. The cash transfer program, which I explained, that's about $200 a month. Just some quick math. So if you've got, let's say, 4.5 million people with disabilities, and you help me with the math here. 4.5 million people with disabilities, and let's say you have a household size of 5. How many households is that have a disability? I'm using easy numbers, okay. How many households would that be? Economics guy. 9 and some zeros. Okay. It's a lot. I'm thinking it's about 900,000 families. Is that right? Am I doing my math right? So if you've got 900,000 families, but you only have 50,000 families participating in this cash transfer program, what about the other 850,000 families? What kind of support are they receiving? Very little to none. I spent some time in two of the slums in Nairobi, and with one family out in Western Kenya, a very poor family. And these are the poorest of the poor folks who have children, in one case more than one, that has a severe disability. None of them were involved in the cash transfer program. Not a one of them. I don't know if that's because they weren't engaged in, or didn't have their birth certificates, or they didn't have their papers, or what the problem was, but they were not involved. So you have to wonder what's going to come of these children. How are they surviving? The program in Western Kenya, in Kisumu County, we did this home visit. The little boy's name was Mishak. He was 3.5 years old. When we got to Mishak's home, it was very clear that he was not thriving at all. His growth is tremendously stunted. He is deaf and he's blind. His skin, I don't know the signs of starvation, but it's clear that he was starving. There were 5 other children, maybe 6 other children running around. There was a mother and a grandmother. As we talked about what was happening to Mishak, they said he just isn't eating. He just doesn't want to eat. He doesn't want to drink. But as we thought about it and talked about it after we left, I do have to say Mishak apparently is doing better, because there was a visit from some outside people and we're watching the family. Mishak is not participating in the family economy. The family makes work, and they survive on 10 cents a day. And there's 9 people that survive on 10 cents a day. There's a father who lives across the country in Mombasa. He comes home, he gets his wife pregnant, and he goes back to Mombasa, and very rarely sends money back. And that's not an uncommon situation. But what we determined is that even though the school from time to time would send home maize mash for the family, and it was meant for Mishak, Mishak wasn't getting any of that because Mishak is not participating in the family economy. The food is going to the children that are helping to make money. That's a sad reality of some of these countries. And I don't know if that happens in the United States. It might. I don't know. But that's certainly something that we saw there. So you wonder, how is this child going to be included if he's not even being fed? How does he get included? Where's the family advocacy for this child to be engaged in school? What's the push to get him there? And I don't know what the answer is to that. In 2016, the country held its very first conference on inclusive education. The second one is going to be happening next month in Nairobi. In that first conference in 2016, they talked about policies and teacher training, just identifying some of the issues of concern. There was no mention at all of early intervention or early childhood education. There was no mention of how to include children with disabilities before the ages of 5 or 6. That is changing this year, largely because of the work that Elizabeth and her colleagues are doing in that country. Other good stuff happening. These folks down here on the right, the white guy is me. The other 5 are 5 of the 6 Kenyan fellows that have participated in the program this year. These, to me, are the leaders of inclusive education in Kenya. Martin, who's here on the left, he went to North Dakota. Jackie went to Nebraska. That's Mary or Maria, I think. I don't know. She went to Boston. Elizabeth was with us, and Faith, on the end, she got to go to Hawaii. That's a tough fellowship. I think she did work, but she did spend some time on the beach. But each one of them is interested in inclusive education. And this is such a new deal in their country, a new idea that they're trying to get together. This meeting was just a chance for them to get together and have coffee. They hadn't seen each other since the 1st of June, and this was the middle of October. We had decided to get together for about a half hour just so I could meet them. 2.5 hours later, I had to tell them that I had to go. And the discussion was about the exciting things that can happen in their country if they work together. And the woman that's third over from the right, I'm going to show you something very interesting that she's doing in the Kibera slum in just a minute. World Vision in Mombasa, which is down on the southeast coast, they're actually doing some inclusive education work as well. That's the 2nd largest city. So there are some efforts. But again, this is all in the last 2 or 3 years that these ideas are starting to gain some legs in their country. I told you about the 2nd annual conference on inclusive education, and Elizabeth and I actually have a paper. I don't get to go, but she's presenting one about the work that we're doing to engage conversation about further program planning. And I just found out 2 days ago that because of the work that we were doing and the connections among these people here and some of the folks that we pulled together while I was here in October, they're going after money from USAID. That's the international, the U.S. Agency for International Development. They are wanting to support county governments. Remember, I told you that these are new entities. These county governments are very new, and they need a lot of support. So we are participating, and UM is going to be participating in this proposal as well, to help them take their policies and put them into implementable programs. And we are gaining funding, hopefully, from USAID to do that work. Babies are such a nice way to start people. This is how I started all of my presentations in Kenya. I don't know Don Harold, but I like what he said. I don't even know if he really said it, but it's a nice way to start people, and it's generally a nice way to start presentations, but I forgot to put it at the beginning of this presentation because I thought the giraffe was much more important. All right, so I am going to get to the collaborative framework, which is what I said I would talk about. When I was in Kenya, my job was not to teach them much of anything, but to facilitate discussion. They have 3 ministries there primarily interested in people with disabilities: the Ministry of Health, the Ministry of Education, and the Ministry of Social Protection. Social protection is akin to our human services. Our job there is to work towards a seamless, coordinated, and structured early intervention program. That's the overall goal. That my visit was there, and that was the goal of Elizabeth's visit here, is to learn how to do that. We recognize that there are strong partnerships that need to be strengthened, that there are existing efforts that need to be strengthened, and where necessary we need to build components. And I'll talk about components of this framework here in a bit. Opening doors. This was at the Ministry of Health. Do you notice anything interesting about those doors? The ministry was open, but the doors were locked, and then they had these metal gates in front that were padlocked. Opening doors is a work in progress, but I just thought that there was something interesting about that. All right, Kenyan families. This comes from a family that was involved with Sense International just before I got there, who said, meeting with my fellow parents and being trained to communicate with my girl and knowing that I am not the only one with a deafblind child, this is a source of hope to me, turning around the hopelessness that I had 3 years ago. That is really what drives all of this. You know, we certainly want to develop programs and engage people and make systems work, but what it comes down to is how we are helping families and how we're helping these children achieve. The work that we did was primarily in these areas. This is Nairobi here. These dots indicate the population centers. This is where most of the population is in Kenya. This is Kisumu County, and this is Lake Victoria. And I'm not real good with anything other than circles. Mombasa is down here on the coast, but this line here from Kisumu to Nairobi to Mombasa is really where much of our work is focused. Yes?
Did you see any difference in the incidence of disabilities, rural versus urban, or different parts of the country?
The question was, did we see any difference in prevalence of disability, urban versus rural? That's not a question that we were asking at that point. What we did see is that I don't know if there was a difference in prevalence, but certainly in the approach to disability. There are certainly more resources in these urban areas, but if you're in a slum in an urban area, you might as well be in the middle of the country. If you don't have access to resources, you just don't have access to the resources. But if you're in rural Kenya, as in the rural US, you're just out of luck. There was an article that came out, digression, came out today in the Washington Post, and look it up. And it said, you know, we have that saying, the middle of nowhere. Well, they've actually determined where the middle of nowhere is. There are 3 places. Well, did anybody see that article? What are the top 3?
One of them is Glasgow.
Glasgow is number 1. Number 2? Scobie, Montana. Number 3? Wolf Point, Montana. We made the top 3. You saw that Washington Post article. It's not much different here. What's interesting about Kenya is that here on this east side and the north side, that's Somalia and Sudan. These are very dangerous areas. So we spend a lot of our time in the south and won't be going up north. Even Kenyans don't go north. It's dangerous. Uganda's down to the south, and Tanzania, well, Tanzania's down to the south and Uganda over that way. But again, the focus of what we're doing is really about the families and their children. So what is collaborative early intervention? This is based on the US system. And this is what Elizabeth was most interested in and is the basis for what she wants to try to accomplish with her colleagues, that it's family-centered, that we're working not just with children, but we are working with families. That it's a family intervention, a family approach, that it's individualized to the needs of the family. In the United States, we call that plan the Individualized Family Service Plan, or the IFSP. That's from our early intervention system. They are looking at developing that sort of system as well, that it occurs in natural environments. In the US, we typically think of homes, but it's not always homes. But where are the places where this child is typically engaged or living, that they are coordinated across systems. And if you recall, we are looking at 3 systems: health, education, and social protection. We want to find a way to coordinate these systems. The thing that the folks really thought was interesting about our system is this whole notion of child find. That's a hallmark of our special education law, both for children 0 to 36 months and from ages 3 to 21. What Child Find means is that the schools, the service agencies, have an affirmative responsibility to find children with disabilities. You can't just wait for them to come to you. The U.S. system requires, the policy requires that we go out and find these children, and we give them and their family the services that they need. So really much of our effort in Kenya is focused now on developing a child-defined system. There's a lot of other things we need to do, but if we can crack this nut and we can start finding the children, we might be able to get the advocacy work going so that we can start doing more personnel preparation and getting people trained to help these families. So what does the U.S. have to offer? This was my part of it. The indicators from the Individuals with Disabilities Education Act, or our special education law, it has two parts to that law that are relevant here. Part C, which is early intervention, that's for children 0 to 36 months, and Part B, which is standard special education, children ages 3 through 21. Because of the Sustainable Development Goals and the SDGs, because this whole devolution idea is so new, they are looking at indicators of progress. There's so much money being pumped into this country that the funders, governments typically, are asking for indicators of progress. So we have shared our indicators with them, and they're pulling out a few that they think are important. Child Find, how does that work in the United States? They're asking us lots of questions about that. Mandatory EPSDT. Anybody heard of EPSDT before? That's something that's part of our insurance, children's health insurance program. EPSDT stands for Early Periodic Screening, Diagnosis, and Treatment. That's a basic policy in the United States that through children's insurance programs, Medicaid is where this is defined, that doctors, healthcare providers have a responsibility for early periodic screening. And if something, pings on a screen, that there's a diagnostic evaluation. And if a child qualifies for any type of service or meets eligibility criteria, that treatment must be provided. That's just part of the U.S. policy. How well it works is a different story, but we have the policy, and it's actually working fairly well in our country. And if you've been involved in any of the tax reform debates and all that stuff that's going on in the last few months, this has been a big part of it. What's going to happen to EPSDT? Because this is a hallmark of the U.S. system. They are interested as well. The Ministry of Health was very interested in ways that we could mandate that early periodic screening, diagnosis, and treatment is happening in their country, but they have a long way to go. One of the folks at Kenyatta University indicated that they wanted a model demonstration center. They wanted a university center that would be the model hub so people around the country could get trained and they could see how it really works. And I was so excited to tell him that I directed one of those in the United States. That's what the Rural Institute does. We're one of 67 in the country that do this kind of work. Some of us are at medical schools, some are in colleges of education. We are freestanding under the provost here, but model demonstration centers are what we do. They're interested in that. And they were also very interested in this idea of developmental milestones. This goes back to the early periodic screening part of the EPSDT. The Centers for Disease Control for the last 5 to 7 years has engaged in a program called Learn the Signs, Act Early. And I've got some information on the back table about that. What are the developmental milestones that children should be achieving at certain stages of their life? They're general guidelines, but they were very interested in what those developmental milestones are and how we define them. So we shared a lot of that information, and they're looking at ways to put those milestones into their policies, but then also into practice. Who needs to be doing those developmental screenings? Is it the physicians? Is it the healthcare providers? The nurses? Who is it that needs to be doing that? So those are the things that we're talking about in our framework. If you've ever been to Nairobi, I didn't take this picture. This is an air picture. This is the Kibera slum. Any guesses as to how many people live there? What do you think? More people than live in Montana. just over 1 million, about 1.2 million they estimate live in the Kibera slum. That's downtown Nairobi off in the distance. I was somewhere down in this area on the edge because the slum is growing. This is considered, I don't know if it's true or not, but they are very proud of the fact that this is the largest slum on the African continent. That's something to be proud of, I guess. Mary, the woman on the far left, on your far left, was one of the fellows. She has spent time with her own time and her own money developing an early intervention, early childhood center in the Kibera slum. She's not from there, and again has exhausted her money and used most of her family's money to do this. She was able to get some funding from a variety of donors to build a new building. And this is on the edge of the slum, kind of on the southern edge. It's about 600 square feet, but you can see from the slum, it's hard to build out, so they built up. And this has 2 stories, so it's going to be somewhere in the neighborhood of 1,200 to 1,500 square feet when they're all done. Having walked around in it, I'm not sure I want to be there if there's an earthquake, or at least I want to be on the top. But it's great. They are so excited for this center where families can come and receive help, where children with disabilities, particularly those who are deaf and blind, can come and receive services. And Sense International is helping them to develop the programs. The reason I include this is because of their financing model, which I think is brilliant. They're doing the standard things like making backpacks and stuffed animals, and they're selling them, and they're putting them out on Etsy, and they're putting them out for international audiences, and that's wonderful. But this is something I hadn't thought about. When I asked, how are you going to fund this? And they said, well, the parents and families can't fund this. And then they asked me a question. Do you have to go to the bathroom? And I thought that was an odd question. And I said, well, not right now. And they said, people who live here have to use the toilet. And if you're lucky enough to have a hole in your home or somewhere near, you can use the toilet. But if you don't, there are certain areas in the slum where you can pay 10 cents, 10 shillings, to use the toilet. I'd never really thought of that. Their economic model, just below here, there's a large room, and they are building 3 accessible toilets, large toilets, and they're going to charge 10 cents a person to come and use that, because people are already paying that money for the toilets. People who are in wheelchairs or have mobility problems have nowhere really to go, and they built this in an area where there's a larger number of people that need that service. Now, when I was down there looking at their construction, I didn't see any holes in the floor. So I'm not sure where the sewage goes, honestly. They're on a hill. Maybe it goes to the person down. I don't know. I didn't ask. But I thought that was a very interesting, it's brilliant, I think. Now, I don't know how hygienic it's going to be, but it's brilliant. I had to walk about 150 to 200 meters down to this place on a path that looks like this. I did not take this picture. And I will say, I didn't take a lot of pictures with people because I didn't think that was respectful. The only pictures I took of people were when they asked me to. Otherwise, I just kept my phone usually in the car because it was safer there anyway. But this is exactly what the path looked like down there. Think about 200 meters or 150 meters walking down this, or a wheelchair. And I asked that question, so you're building this accessible toilet facility, how are people going to get there? And they said, well, the community's helping us. As we walked back up, we got up to the car, and I was met by a little Somali man named Mohammed. Mohammed is the elder of that part of the slum. He had heard that I was there, that an American was there looking at what they were doing, and he was so proud of what they were accomplishing here. He wanted to come and tell me how proud they were of Maria and the work she was doing, how excited they were to have this, this early childhood development center in their slum, and that he was gathering the resources and the people to make an accessible path. That's what the community was doing to help this out. I thought it was brilliant, and I can't wait to go back and see what it looks like when it's open. This was a classroom That's Ms. Beatrice. I mentioned Ms. Beatrice a little bit ago. She's a teacher. She teaches pre-kindergarten and kindergarten. Now look at that class. Mr. Aguyo there, he's kind of a district guy. He works for the county government. How big do you think that classroom is? How many meters by how many meters? What do you expect? I mean, estimate.
7 by 7.
7 by 7? How many square feet is that?
Now you got 49 square meters.
49 square meters, so
It would be 20 by 20.
yeah, okay. Yeah, 400 feet. How many people could you comfortably fit in a space like that? Say 400 square feet. How many would you want to fit comfortably there? 20 people? 25 squished, 30 would be full. This is one of 3 classrooms in this school that's a pre-K, a pre-K, and a K. The smallest of those classes has 68 children in them. This class here had 72 enrolled students every day, all day long. 72 students. So, you know, that's a wow factor. Now, think about inclusive education. Miss Beatrice is the only teacher. She has 72 children who are typically functioning. You put 1 or 2 or 3 or 4 children with a disability who don't hear as well, who don't get around as well, who don't see as well, who maybe can't manipulate things as well. How in the world do you accommodate those children? We've got the policy that they have to be included or should be included in their neighborhood school. But that's impossible. Maybe not impossible, but one teacher for 70 children, and you put in a child or 2 or 3 with a disability, and with very little training on the teacher's part, how in the world do you serve those children? That is what these folks are up against. That's the challenge that they are facing. This is a picture. You can't see it real well, but the classroom before, they met under a rock and under a tree. This was the small group. I think there's about 55 kids here. This is a class and a half. There's almost 100 kids there. And these are 3, 4, and 5-year-olds. Would you like to be in a room with 73, 4, and 5-year-olds? Quick story. Oh, I guess I got to hurry, huh? Quick story about this school. It was late in the afternoon. The students, there were probably about 300 kids total in this school. 300 or 400 kids, maybe 400 or 500. Anyway, they were out in the yard area. The roads were so bad that we couldn't pull up into the school area. So we got out. We were going to make this visit. And as we started to walk. All the kids were outside getting ready to go home, I guess, or whatever they were doing. And they were all together. And to add to it, I had a bright yellow shirt on. So I'm walking with my colleagues. There were 4 or 5 of us. And when they looked over, within 3 seconds, it got deathly quiet. And in fact, I was walking, and the person next to me said, "I'm not walking next to you. They're all staring at you." And they were all staring. And I got about 10 meters from the group, 30 feet or so. And I heard Mzungu, which is like white boy. And it was a little boy. And it was always little boys that would yell Mzungu. And as soon as they yelled that, then everybody laughed. And then everyone wanted to give me a high five, and it was fun. But this was out in Western Kenya where they weren't used to seeing Europeans or Westerners. But it was great. Then we went and saw the classroom. But I wear the title Mzungu with pride. Next steps. There are a lot of things that we can be doing. Personnel development and preparation. We need to figure out how to prepare teachers, to prepare providers, to prepare the health care professionals. With assistive technology, for example, that's an interest of mine. Deaf education is something that they're very interested in, particularly for the kids who are deaf and blind. This group of people here, this is national government folks. They can only do so much. Remember, devolution. They've given all the power and the responsibility to the county governments. So we need their buy-in, and we need them to say, yes, inclusive education needs to happen, and these are the programs and policies you need to put in place. But the real work happens at the county level and at the university level. This is the dean of Maseno University, and we're actually looking. Anybody here from the CSD department? Communicative Science? Woohoo! All right. we're looking for ways to connect our undergraduate students and graduate students from the Communicative Sciences and Disorders Department with their special needs education department as well. I don't know what that's going to look like, but at least getting students talking back and forth. Kenyatta University also has a special needs education program, and we are looking at connecting students there. At the University of Nairobi, my second day there was closed indefinitely because of political unrest. I don't even know if they're open again, but we want to connect with them at some point too. But personnel development and preparation, that is a next step. That's something that we need to focus on. So we are working with the other fellows that are involved with KISE. Martin, who he was one of the fellows, he's a teacher trainer at KISE, so he's involved in our work as well. Policy development and integration. We know that they have policies, but they're not well implemented. Can anybody see what this is right here? That's a ramp. That is the, does anybody know what I know Alexander knows, but what is the correct pitch for a ramp under the Americans with Disabilities Act? Anybody know? For every foot of length, it's an inch of rise. Now, I don't know what the percent is, right? So if you're going up, I don't know how many feet that is. You know, 1, 2, 3, 4, 5, 6, 7, 8 times. That's about 56 inches, roughly. That means that ramp should be 56 feet long. And it's not, yeah. Yeah, it's like the ski thing. That was the accessible entrance to the nicest hotel in Kisumu County. I had to take a picture of that. That was fascinating. We talk about putting policy into practice at the local level. These folks here are Kisumu County, Western Kenya, and they recognize that the power and authority and money has been devolved to them. So we are working with them to develop a pilot program, an early intervention program that has the components we've been talking about. We're helping them to develop that in their county. Kisumu County is a very interesting place. Per capita, it has the most educated people. For some reason, I don't know, that county has all of the educated folks there. I don't know why that is. In fact, the governor does not like to be called governor. He likes to be called professor because he was a professor. And so he will ignore governor, but he does like professor. And he's an interesting man. His name is Professor Nyong'o. And this part of the country of Kenya is known for two things. One, the governor's daughter is Lupita Nyong'o, who's an actress. Some of you may have heard of her. And he is I had a chance to, I'll tell you about my meeting with him. He's a delightful man. And the other thing that they're proud of is that they gave us Barack Obama. They're very proud of the fact that he is from Kisumu County. When I went in to see the governor, we waited to make a courtesy call. We waited about an hour to go see him. And this is just an aside. When we finally got in, we had been waiting a long time. We were tired and we were hot. And we walked in, and he started talking to me, bonjour, and he started going off in French. And I don't speak French, but I knew enough to know that he was speaking in French, and I had a sense of what he was saying. And I looked at him funny. And then he said something else in French. And then he asked me if I spoke French. And I said, no, I'm an American. And he started laughing. He said, oh, he said, they've been telling me all along that you were from France. And I was excited to meet a French guy. Well, he wanted to show off. If I had known that he had actually lived in Mexico, I'd answered him in Spanish, but I didn't know that at the time. But anyway, that was a complete aside. Kisumu County is where the action is. Next steps, the final thing here. We recognize that this is going to take a lot of patience and a lot of ongoing assessment and process. If we want to get to outcomes, we need to figure out how to combine the systems and the data and the practices together. That is how we're going to make changes. This seems maybe real high level, but if we don't have our ducks in a row with systems, data, and practices, we're never going to get to the outcomes that we need to get to. So this is what we are working on. The framework, this is what we're about. The components is coordination and communication at the national, county, and local levels. technical assistance and preparation. I don't have to read all of that, but these are the things that we are really focused on. The activities that we're engaging in over the next 6 months are there towards the bottom. We're in the process of developing a technical working group, which my visit in October was to begin the establishment of that, to bring people together who had like interests and a desire to develop an early intervention framework in the country, but had never spoken to each other. My role was to help open those doors. It's interesting that I didn't say anything that wasn't already being said by them individually. It just sometimes takes someone from the outside to see it, or at least to open the door so they can talk to each other without yelling at each other or disrespecting each other. Interagency partnerships and agreements, we're working on that. Funding, I told you about some funding that we're going after. Civil society. Civil society are the advocacy organizations. And we again started by bringing some of those folks together that had not come together before about inclusive education. They were all doing their own thing. They were very disorganized. And establishing a model demonstration center. These are the benchmarks that we have there in bold there. But these are the things that we're working on. This is very new. As I told you, 10 months ago, I didn't dream that I'd ever go to Kenya. In the last 10 months, this has all come about, but I see this as a lifelong mission, I guess, as it were. Kenya's future. We talk about education. This woman, Madam Chirono, she's the very first director of special education services in the country. She's had her job since 2015. This is all a very new idea. It's not a new idea, but the policy and the programs together are very new. They're very, very new. And how to go about serving children with disabilities and their families, they just have very little idea how to do that beyond a very local level. How do you do that from a policy perspective? Kenyatta University, some great students. They're just wonderful people. To me, I look at this picture, these various pictures, and this is the future. This is a group of people that it's the Action for Children with Disabilities. Most of these folks are parents of people with disabilities. Not all of them, but most of them are. They had never had an opportunity to get together with government officials who, some of them are here. They had never gotten in a room together. And our visit in October was the first opportunity for these folks to start talking about some of their interests and concerns, to see where they overlapped and see where they didn't. For those of you that are students here, her name is Sarah, I think. She was what do you call that? Not a transfer student, international student, study abroad student from Florida. And she went to Kenya for an international study abroad, and she loved it. So she went back and is now getting a master's degree at Kenyatta University. And the Kenyans tell me that she speaks Kiswahili better than most Kenyans. But we had a good time meeting her. Anybody know anything about autism? A little bit. One of the best interventions, not the best, but one that is used a lot is behavioral analysis. They recognize that behavior analysts need to be trained to work with kids with autism in Kenya. Right now there's one certified behavior analyst in the country of Kenya, one that's registered. The second is her, and she's just finishing her certification. So they're happy to have her. So Asante Sana, thank you very much. I probably talked too long, but if you've got any questions, I'd love to entertain them. But that's the work we've done in Kenya. This is the first step of a long, long journey. And I thank you for your attention.
We have time for a few questions.
Oh, before I get to questions, so you can't see this real well, but that's a lioness. I took that picture from a car, and that's not a zoomed lens. We were less than 5 meters from Simba's mom. Really stupid. They'd never let you do that in the United States. Any questions? Yeah. Well, there's one here and then one here. Go ahead.
Has the political situation any effect
Good question. The question is, has the political situation in Kenya affected our work? Absolutely. For those of you that are not aware, President Kenyatta, Uhuru Kenyatta, was elected in 2013. The next election happened in August of 2017. He won, Kenyatta won, but Odinga, who is from Kisumu County, which is the lead opposition county, he put up a stink, and the Supreme Court nullified the presidential election. I was actually supposed to go earlier in the fall, but because they were expecting elections, they put them off. The second election happened at the end of October, a week and a half after I was there. 2 days before, the opposition leader decided that he was not going to participate in the election, so Kenyatta got elected, and now they're having all kinds of problems. It has, because now it's affecting our work for two reasons. One, it's not safe to travel for Kenyans or for Americans, and the main opposition is in Kisumu County in western Kenya, which is where our pilot place is. When we were there the week and a half before the election, luckily we had a driver, Walter, who didn't want to get involved in the riots any more than we did. And we came through, and everywhere we'd go, there were burned out tires that had been burned out earlier in the day. And one place we were at, about an hour later, somebody was shot and killed. And these were just city streets we were on. So it's a volatile place.
Before you get too interested in the Paying to Pee, I think you should see the musical comedy Urinetown, which is about paying to pee.
Paying to pee.
But seriously,
Thank you, Alexander.
yes. But seriously, on another economic model to consider, which I saw in India, connecting with the adult system, and we have a fairly unique vocational rehabilitation system in this country where we invest in people. But building off your first statements, that's a family thing and it's poverty. One model has been to enhance the economic capacity of the family, but not the person with a disability doesn't get vocational rehabilitation, but they provide training to another member of the family so they can get a higher paying job, and it increases the economic capacity of the family. And I don't know, that would never work in our country. But I don't know if it will work in Kenya, but I think it's a model worth considering of strengthening.
That's an interesting point because of the I don't know what they call them, but the women's employment movements, loans, microloans to women. The whole idea behind that is if you improve a woman's ability to earn for her family, it improves outcomes for the entire family. That's
Something to bring in and then connect it in with how they look at adults.
That's an interesting point. Thank you. Alexander is one of my mentors for over 20 years, so I know that she'll come back to me on that one. Peter.
I found the devolution aspect quite fascinating because that's where I did my dissertation work on in Ethiopia. I wondered if there's any room or any value in an educational program that involves something like our minor in global public health here, a broader perspective that people working at the county level have to deal not just with disabilities, but with the whole ramifications of transnational or global health today.
I would think so. I don't know where you would start with something like that with the county governments. I don't know, but I think so. I think people need to. I think one of the challenges that we've had in this country is that we have siloed disability in a way. And so it's everybody else and people with disabilities. And I think that actually in the long run, in the short run, it makes sure that people with disabilities get the services and supports they need. But in the long run, I think it does a disservice because it continues to keep people separate. So maybe that's a lesson we can share with them is, look at these issues more globally as a public health issue. Maybe that's what you're saying. There's a question here.
Yeah, more on the devolution model. You said it's equivalent to like block grants. Given the political tides in central government, are the communities facing that tough decision, like we're getting this block grant, how much can we devote towards early intervention and those sorts of programs? Like where on the priority list do you think that is in these communities?
I don't think it's terribly high on their list. The question is, how high is early intervention or early childhood education how high is it on the priority list when they're getting this big chunk of money? I don't think it's very high. However, if the people giving the money say, you need to be focused on Sustainable Development Goal 3 and 4, it automatically jumps up. So tying any money that goes, whether it's from the central government or from outside sources, any of that money that's tied to the SDGs, I think, SDGs that we're interested in, not the other 15, which are important too, because they're very important, but that's the way to bump the priority up. And the other part of that is the indicators, and that's why the folks that we were interested in, that we talked to, were so interested in the indicators from our special education system, is they finally had now a measurement that was being used in another country that they could use in their country. If you don't measure it, nothing happens. If you measure it, then it gets attention. So that was their interest in indicators. Good question.
Bill, I think you've all enjoyed the presentation tonight, and please join me in thanking Martin for taking the time to come and share with us his really interesting experience in Kenya.